All right. After attending Davidson College and graduating with a BS in biology, Dr. Stephen Lewis spent 6 years doing basic neuroscience research. He then attended medical school at Wake Forest University, interned at Abingdon Memorial Hospital, and was a resident at neurology at Thomas Jefferson University Hospital. Board certified by the American Board of Psychiatry and Neurology, Dr. Lewis is currently self-employed in solo practice with offices in Willow Grove, Pennsylvania, and is on staff at Abingdon Memorial Hospital. Dr. Lewis has always been interested in the unusual neurological diseases and became specifically interested in the periodic paralyses when he made the diagnosis in a friend patient who had been passed around the Philadelphia medical community. She and Dr. Lewis worked together to discern a treatment regimen that works for her. He believes that disease management is best when directed in a controlled setting with frank, open discussion and a partnership between patient and physician. Clinical management of few, if any, neurological conditions can be cookbooked. In other words, each person is different and needs to be treated uniquely. Ladies and gentlemen, please welcome Dr. Stephen Lewis. Do you want it on here?
Yeah, we'll try it on there because I hate holding it. If I have to hold it, good. Here's. Yeah, that's probably there. Which one is me? There we go.
Okay, it's running.
Okay. So this is all new to me, kind of. So I like this little platform here because we get to keep our feet on the ground, right? So we're going to simplify things. We've seen lots of really fascinating science, really neat diagrams of, what we believe is going on here. This doesn't want to work. There we go. So, again, just a quickie about me. I put the last little line on the bottom there because people do send me a lot of stuff and it ends up in a different shaped file cabinet, if you know what I mean. So if I don't know you, don't send me stuff, please. So the neat thing about what I do as a private practice neurologist, solo practice, is I get to work for myself, which means I get to work for you. I work pretty much when and how I like to. I get to spend as much time with patients as I need and consequently as much time as you need. I don't have partners, and so I don't have to hang out with whatever they have to say. You can see there, I've got a bunch of patients now. We're somewhere up around 80. That's what I counted in the file cabinet before I left the other day. That doesn't count what's on my desk, and if you've been in my offices, you know my stacks of papers. I'm really not a bean counter, so I can only guess that only about a third of the patients that I have actually have a proven genetic, one of the big four. Most of the people that I've sent off for testing genetically have some glitch somewhere, and most of them are, it's amazing, 4 and 5 variants. And, again, once in a while I get somebody who thinks it's a periodic paralysis and it's something unrelated, but, that's what I do. So, everybody likes to talk about zebras. I think zebras have, they're neat animals, but as far as I know, there are only 2 kinds. Anybody know what these are? No. So, these are camelids, of which there are 4 different types, and we'll get to what they are. But you can see when they're all together there's slight differences between them. So we're going to talk a little bit about the history of periodic paralyses. We'll whisk at the types because that's already been gone over. Causes, diagnosis is my approach. Treatment, we'll talk about drugs. I mean, it's nice to think about the theoretical things that are coming. Right now we have the handfuls of pills and medications and therapies that we currently have. So this one, which one's that? Lama. Lama. Okay, so the earliest description that I can find is by this guy named Kavari, who keeps getting cited, but we can't find the original paper. Has anybody else been able to find the paper? It's referenced all the time as the earliest description, but yet the paper can't be found. It wasn't until the early 1900s that, and that's a clinical description, right? We didn't know about DNA, we didn't know about protein synthesis, any of that kind of stuff back in the 1800s, and even in the early 1900s, you know, it was discovered that potassium salts could be used, and then it wasn't until the 30s that they started noticing fluctuations in potassium, and that then thyrotoxicity at the same time was thrown in there. I kind of, not to offend anybody, I always feel like thyrotoxic periodic paralysis is a secondary paralysis. So I kind of break them up this way. The hypokalemic, hyperkalemic, Anderson-Tawil. Of course, the normal kalemic seems to be what shows up in my office a lot. I put a chloride channel in there because I have a guy who has a chloride channel abnormality, and he looks, acts, reacts, responds, behaves exactly like hypokalemic periodic paralysis. And always something else. The last line there you'll all appreciate, because I'm sure many of you have heard that as one of the causes for your symptoms. I personally, I'll stand here in front of everybody and say I think Sigmund Freud did us all a bad service by naming physical abnormalities that he didn't know what they were as psychiatric disorders. Oh, too fast. So, alpaca, a little shorter and fluffier. Genetics. We had a lot of genetics about that earlier, and again, lots of other stuff going on, and the last line, we don't know. For the clinician, again, I'm a clinician, not an academician. Most of it is, we don't know. Does it really, it doesn't make a lot of difference in what your type is to how we treat. As we said, causes often something else. So here's a wild type. Anybody know that one? National animal of Peru. Yeah, there you go. And it's felt to be the wild version of the llama, which is the domesticated. And so in the diagnosis, as I said, this is where it gets tricky. In medical school, we're taught that the diagnosis is a combination of history and physical. In neurology land, it's mostly history. There's not necessarily a lot that we learn extra from the physical exam, but nonetheless, the first thing to do is go to a physician. And I stress the physician, not that there's problems with physician extenders, nurse practitioners, PAs, but their primary benefit is in the usual and sundry medical conditions. And the unusual things is what the physician training is there to pick out. Tell them the history and try to be chronological. That means from the beginning, from your first time that you felt that something wasn't the same as everybody else, what was different? Anybody in your family, it's important. Who I usually say is their cousin Joe in the back room. You know, somebody else that nobody likes to talk about. Medical terms, doctors don't understand medical terms. And so when you throw medical terms out there in the history, I don't want to say you confuse the physician, but it makes the doctor think that you already know what there is to know. And so then why are you there? So I just when patients come to my office and use medical terms, I kind of try to put the kibosh on it and have you speak more into how you feel, what's happening with you. Next line there. Don't be disparaging of healthcare workers. We all try our best, I hope. And yes, many of you have been mistreated in some way or another. Many of you have gotten treatments when you insisted that you didn't need or want them. Many of you have had lack of treatment when you needed treatment. When you speak to a new doctor about how you've been mistreated by other doctors, we kind of put a barrier up unintentionally, I think. I think it's clearer to talk to other physicians when you are fully upfront. Provide documents. I mean, if you've been to see other doctors, and certainly in my practice, most of my patients have been to see 8, 10, 12, 15 other physicians before they make it up to Willow Grove. Bring the papers with you. Sometimes I look at them, sometimes I'll borrow them from you, sometimes I'll let you keep them. Depends on what all's there. There's a lot of extraneous paper in medical care. The electronic medical record is really added to paperwork. So then again, after you've given a good, clear history and you've been sure to explain the way you're afflicted by this disorder, if he needs an examination, I mean, hopefully at least blood pressure and heart rate, going to look for some physical deformities. You know, my old chairman at Jefferson says you're not a neurologist unless you've looked at the person's feet. So shoes come off usually. And you don't have to, you know, it's like for me to see an epileptic, I don't need to see somebody having a seizure. If they can tell me a history, or their family can tell me the history of a seizure, or whatever goes on. I don't need to see it. You don't need to show me. Once in a while, if I can't make heads or tails out of how you're describing your weakness event, I'll have you show me, but pretty much unless I asked for it, I don't need to see it to believe that there's something wrong. Dr. Google card. How many people out there have Googled their illness? Yeah, I mean, if you haven't, you probably don't have a computer or a cell phone, or, and you know, we like to say that, you know, your 3 minutes, 3 hours, 3 weeks on the computer doesn't match up with our 4 years in medical school. Ooh, some of you guys are smart enough to learn all of that, what we learned in medical school in that short amount of time. But telling us, well, I looked on Google, and my wife, who's down here in the front, is a medical librarian, and Google is just the edge of the coin for her. It's nowhere near the be-all, end-all when we need medical information. So after all is said and you've been looked at, then there's a bunch of tests. Genetic testing has become a lot more available thanks to Strongbridge Biopharma for involving Invitae, and of course Fullerton Labs with Dr. Charlton. Has been doing great jobs on the genetic testings, and you know, it helps clinically. And again, as a clinician, the purpose of the genetics is it gives you a flag to wave. You know, when you are down, when you're having a problem, when you go see another doctor, you end up in an emergency room or in the hospital having a colonoscopy for something, you've got this flag to wave that says, hey, look. But that's about all it stands for. Right now, we cannot treat genetic illness. We treat the symptoms, okay? So other testing that we need, metabolic panel. Hey, you know, it is really great if we can catch a change in your serum potassium level during an episode. How often does that happen with any of you? I mean, by the time you get to the hospital, you're starting to feel better. By the time they decide that they want to draw your blood, one of you mentioned to me that she was in the hospital and had an attack, and she said, here's the prescription from Dr. Lewis, can I get my blood drawn? And they said, no, we have to evaluate you first. And by the time that happened, she was better. So what happened to the potassium? I don't know. It's easier said than done. The reality is another story. Electromyography, nerve conduction studies, all over the web, everybody goes, ow, ow, that hurts. Sorry, we don't mean to. I would never, how's that for a word, never base my diagnosis of a periodic paralysis on that particular series of tests. It can add to it, but it more likely will tell me that there's something else going on. Urine electrolytes, some people forget, hey, you can just be peeing it all out. You got big holes, you got other nephrotic syndromes, Barter's syndrome, Gardner's syndrome, et cetera, where your kidneys just open up and all the potassium goes out. Thyroid functions, obviously, as we said, looking for thyrotoxic, but people can, besides having thyrotoxic paralysis, people can be weak from hypothyroid or even hyperthyroid. You're just weak. Muscles don't work right when the thyroid gland is off. Other testing, EKGs, echocardiograms, you might need to see a cardiologist, a nephrologist, psychiatrists, dietitians, physical and occupational therapists are all really helpful in putting in their two bits, so to speak. Occasionally neuroimaging, spinal taps, lumbar punctures may be beneficial as well. Neuroimaging, again, shows us what the brain, spinal cord looks like, and that's when the examination shows me something that I didn't expect. And once in a while, again, that's the off. We're looking for other things. Another animal. This one. This one makes really wonderful coats that are really expensive. Okay, it's a vicuna. And he's the wild version of the alpaca. So, after sorting through all of that, what are we going to do? How are we going to treat you? I mean, that's kind of a no-duh statement. Depends on the diagnosis. The diagnosis can be a working diagnosis. I don't necessarily know the second I see you, and even after 2 or 3 hours with you, I may not know exactly what to call your disorder. But this doesn't mean I can't necessarily help, that I can't give you some medications, some sort of treatments. So some quick rundowns of some ways you might be treated. I left the first line there as potassium salts. That's potassium chloride, potassium bicarbonate, potassium gluconate, okay? And the formulation that seems to be patient contingent. Some people like the chlorides, some people like the bicarbonates, but those salts are short acting, and then you can have an extended release product. I kind of look at the potassiums for the hypokalemic folks as a baseline. So if you have a baseline blood level, say of, can we say wishful thinking here at 4.3, 4.4, anybody? If we can hold you there and an attack comes, you're not going to fall, you don't have to fall that far. And so that the recovery period is quicker and easier. The carbonic acid anhydrase inhibitors, Keveyis, as has been mentioned, is the only drug that's labeled by the FDA for the management of the primary periodic paralyses. That doesn't mean it's the only drug that can be used, right? It really is a good drug. It's a very potent, concentrated product. I don't really want to get into the differences and the pros and cons between them suffice it to say that I have patients on everything that I'm going to show you here. Diamoxacetazolamide has been the gold standard, or at least the standard. But for me, topiramate, the drug Topamax, was the drug that got me involved in the periodic paralyses to begin with. So that patient friend that was mentioned in my bio up front was told that she had, by the mega gurus in the Philadelphia neurological community, after seeing everybody, that everything about her was compos mentis, shall we say. She was not all together upstairs, and she's about as together as I think I am. In any case, she was eventually told by somebody that she had atypical migraines and discharged. And that allowed her to come back to see me, and I said, well, if it's atypical migraine, so this is 1998 or so, I said, well, there's this drug on the market that we're using a little bit to treat migraines as before its FDA labeling for migraine control. And we put her on some Topamax, and she immediately started to get better, started to have fewer attacks. We started talking about, what is it? What is it about Topamax that is helping these attacks? How does Topamax work? And we settled on this carbonic acid anhydrase inhibition. That's the enzyme that we all have in the body that helps to regulate our pH. And when you inhibit that enzyme, it makes us all a little acidic. And we've heard from speakers earlier about how that acidosis helps the recovery. That patient has subsequently gone on and really has pretty good control of her symptomatology. I've had other people who Topamax is a little bit, shall we say, strong. I switched over to zonisamide or Zonegran. Similar mechanism of action, but a different metabolism. It's metabolized mostly through the liver. As I say, whatever that really means to the patient. It's smoother and easier, but at the time, it only came as a higher dose pill, and it's a capsule, so it was harder to spread out. It now has lower doses so that it's easier to dose. Some people, again, despite those two therapies, still need something else to help hold the potassium at a minimum baseline. Spironolactone and eplerenone have been sort of the mainstays, but some people don't tolerate those, and amiloride and triamterene, which is harder to find. Usually you find the triamterene in diazide mixed with hydrochlorothiazide, which is a potassium-wasting diuretic, so that kind of defeats the purpose in the hypokalemic folks. So the top three get more use. The hyper folks, again, the same carbonic acid anhydrase inhibitors. Interestingly, higher doses of those will tend to help drive the potassium down a little bit, but that's whether the patients will actually tolerate real high doses, somewhere in excess of 1 gram a day, for instance, of Diamox. Acute attacks managed with sugars, straight up Coke. I've had some people who like the taste of Caro syrup. Liquid chocolate, that's cool. Sugar water, things like that all can be very beneficial at relatively rapidly dropping the potassium. Everybody talks about albuterol inhalers. Not to put anybody on the spot, but I've not ever really had any significant benefit from them. My patients say, well, you gave it to me, I tried it. Are they not inhaling it correctly? It takes some practice to time, or else you have to get the extender piece that fits onto the end of the contraption and figure out how to suck it down at the right time and when you're feeling weak. Good. So, again, albuterol is there, but I never get much use out of it. The mainstay really seems to be the potassium wasting diuretics, hydrochlorothiazide and Lasix being the top two. Sometimes the angiotensin converting enzyme inhibitors, things like lisinopril and captopril stuff, can enhance that potassium wasting in the diuretics and make it a little bit easier without having to go up too high on the diuretics, because who likes to be running to the John all the time when you're weak? Anderson Tawil, I've 1, 2, 3 people come to my mind. It really kind of depends on which way they swing. Some of them are primarily hypo. Two immediately came to my mind, primarily hypokalemic, and another patient started off really hypokalemic and is, if anything, hyperkalemic now. She can tell the difference in which kind of attack she's having, so that usually she doesn't have to experiment and say, well, give me the Coke, and find out that she really needed potassium. In the Anderson Tawil folks, there's extraneous treatments, beta blockers, pacemakers. That's where the cardiologists really come into play. Herds of other drugs, because remember I said, as in clinical medicine, clinical neurology, what we're looking at is symptom relief. So what's bothering you? Pain is a big component. I got a phone call from a pain doctor a couple of weeks ago that he was the primary doctor taking care of a guy with a hypokalemic periodic paralysis, and his main complaint wasn't attacks of weakness, but rather this chronic pain in his muscles. A variety of things get tried. Emphasis on tried, because there's no correct answer factor here. But muscle relaxers, non-steroidal, anti-inflammatories, that's the Advil, Aleve kinds of stuff that everybody's tried. Gabapentin, Neurontin, anti-muscle spasm meds like baclofen and tizanidine or Xanaflex can be real helpful as well, particularly if there's muscle spasms are keeping you awake at night. Sleep aids, I put that in there because I've seen a person who was her again, use of the word paralysis is better defined as catatonia. She would freeze and stick in place and is unable to move. And there's some recent studies looking at Zolpidem or Ambien in those folks, and so she's giving that a go right at the moment. Depression can be a major component. This SSRIs, the selective serotonin reuptake inhibitors, the Zolofts, the Prozacs of the world, Lexapro I particularly like, escitalopram. I avoid these in most patients, the serotonin norepinephrine reuptake inhibitors, because the norepinephrine, another name for that is adrenaline. And I've heard a couple of people around here talking about their adrenaline sensitivity, and so, or sensitivity, excuse me. So I would kind of hesitate to enhance their adrenaline effect with those medicines. There's some people out there who, in the differential, in the list of diagnostic possibilities, I'm sure most of you have been tested for myasthenia gravis, a neuromuscular junction disorder. And one of the therapies that's used there is methadone or pyridostigmine. It kind of pretends to be acetylcholine. It kind of pretends to activate the acetylcholine receptor and allow muscles to contract, and that whole cascade of sodium and potassium shifting with chloride, et cetera, which everybody's talked about, but doesn't really matter. Some people get a lot of gastrointestinal things, and I find that the pyridostigmine has been beneficial with some gastroparesis sorts of things. It sort of stimulates the guts as a side effect, if you will. Rest is both a bane and a boon. You heard about the the warm, slowing down gradually after exercise so that you don't get an immediate flare-up afterwards, important. And I've had several of my patients actually notice that phenomenon. Most of the, from here on, you're going to see it's you. This is what you live with, okay? You have to know your limits, know how far you can push yourself before you're going to start falling down on the tennis court, before you can fall down walking the 3 football fields down the corridor here. Know your diet. What kinds of carbohydrates can you tolerate or need? Look for triggers. Again, foods are common triggers. And we're generally speaking, food triggers are triggers in the very, very near future, like in the next hour. We're not talking about, oh, I ate a pizza today, I'm going to be weak 3 days from now. In fact, the chloride anomaly guy that I mentioned, I'll make a quick tale with him. He came in to see me. He had just ridden his bicycle across the country, and sorry, Gabe, not you. He came back and he was totally fine. He went out for a jog around his parents' neighborhood and felt this sudden overwhelming urge to sit down or he's going to plant his face on the ground. And so a guy who rides his bicycle across the country, taking a 2-mile jog around a neighborhood, I don't think he was going to get dehydrated. But yet the neighborhood cardiothoracic surgeon stopped by, picked him up, scooped him into his car, took him down to the emergency room, and they said, oh, you're dehydrated, here's some potassium, you'll feel better, which he did until his subsequent attack, which then allowed him to come in to see me. And fortunately, he just lives in Philadelphia. But in any case, he called me up one night, a couple of days after our second visit, and he said, gee, Dr. Lewis, I just went over to a friend's house, and, he was 25, 26 years old. He said, I had a couple of beers, a couple of slices of pizza, and I realized that I had a paper to finish writing. He was a graduate student. So I ran back to my apartment and up the 2 flights of stairs. This is the story of twos. And he said, I almost couldn't get my key in the lock to get back in my apartment. Okay? Example of food triggers. Hot and cold temperature, hence the warmth in here. Most of you are cold sensitive. Stress, I like to say it makes the world go round, but you have to find a way to deal with it, and sometimes that's those SSRIs that help to even that out if you can't handle it well enough on your own. So, in terms of prognosis, everybody says, what can I expect? I've seen everything. And looking around out here, I continue to see everything. I've had patients come to my office spending 8 years in a wheelchair, come to my office the second visit a few months later, walk into my office and say, oh, I left my cane in the car. Sometimes it's as simple as that, just getting the right regimen of medications that help stabilize the complaints. Most people lead productive lives, work around their triggers. Interestingly, I will say that I think that the people who get diagnosed at a younger age and have a hypokalemic periodic paralysis syndrome seem to require lower doses of fewer numbers of medicines. Not everybody, but that's one of the truisms that I see frequently. But, above all, remember that, the periodic paralyses, these genetics, it's the color of your hair, and yes, some people can change the color of their hair. It's it's your brain, it's your fingers, it's your toenails, it's your genetics, and how you work with that, how you can adapt to the difficulties, I don't like to say disabilities, but the difficulties that it inflicts upon you at different times, it comes and it goes, is important. Getting past those stumbling blocks and, again, finding a physician who can talk to you, work with you, prescribe medications, and not say, oh gosh, 40 milliequivalents of potassium a day, oh, you're going to die. It is the last thing that a convicted murderer sees in the needle, though, so keep that in mind. Doctors are afraid of too much potassium, but one of the things that I've actually seen, and it's harder to do with people who come from afar, but how much potassium can you tolerate before you get a potassium? I mean, have I ever seen somebody who has a hypokalemic periodic paralysis with a potassium over 5.3? No. Intravenous is another story. If you go to the hospital and they say, oh, look, your potassium's low, and they start cranking it into, sure, they can overshoot you real easily. But oral potassiums, it just doesn't seem to happen. Going the other direction, dropping it down low, yeah. Certain people around here have tried to see how low they could go to make a video, right? And it's a rather dramatic show. Again, in closing, there are these animals. They look an awful lot alike when you think about them, but when you look at them, they're all different. They go by different names. They're similar. They're all in the same family, kind of like these disorders. And I think that there's also a difference in the tame versus the wild type. So once we get you under control, you get tamed, and we can pat you on the head like so many of these nice little doggies. Ever the librarian, my wife put together some websites that have some basic information. If you haven't been to these sites, they're good, well-received medical sites. You see from the NIH, the last two, and Medline Plus for the first one. And I think you're putting this out on the website, right? Sure. You're putting this out on the... Yes. Yeah. Okay. So you can look these up later. You don't have to write them down or take pictures. So that's about all I have to say about that. I'm sure there are questions.
There's a bunch. I have a couple. So thanks for that great clinically focused talk. It kind of brings us back to very practical matters. My first of three questions is, can you talk to 3 or 4 things it might be if it's not periodic paralysis that maybe some people in the room, even they think they have periodic paralysis, but maybe they have something else. Just in terms of, opening your mind a little bit. And maybe it's not an issue for people, but...
Yeah, it's interesting, though. From my perspective, again, by the time people come to me and because of you guys, most people have been to see, multiple other physicians, so they've had the tests, and it's not like, Dr. House, who comes up with the new differential and says, well, I have to do all those tests all over again. So by the time people come in to see me, the epilepsies have been excluded.
How? What, by EEG?
That's what I mean. So that most people have had them by the time they come see me.
Like myasthenia gravis, it's just a blood test, or what?
I'm sorry.
MG.
Oh, and for myasthenia gravis, the easy thing that happens out of most of the family doctors and stuff is a test for the acetylcholine receptor antibody binding titer. There again, if that's negative and people give a good history of weakness that occurs immediately after exercise and it is improved with rest.
All right, and then Bartter syndrome. I'm just going to run through the list of things in my head that. So Bartter syndrome. Bartter. So it would be like, would that be urine electrolytes or?
I'm sorry, I can't hear the word.
Bartter.
Oh, Bartter. You know, again, getting the urine electrolytes and making sure that you're not wasting that way.
Oh, a few conferences ago, you were talking about like, you know, sleeping disorders, the narcolepsy, the cataplexy.
Yeah, sure. I'm not a real big believer in sleep studies, to tell you the truth. But certainly the narcoleptic disorders and should be excluded. Again, there's sort of magic words that people come and they say. Neurology is all about magic words, and so I hate telling all my magic words. If you hear the magic words, then you need this kind of a test. But yes, you know, again, I've not had anybody come see me thinking that had a periodic paralysis that turned into a narcolepsy.
So basically, the majority of folks, if they have episodic weakness, some problem with potassium, either they get better with potassium or their serum potassium is low or high during an attack. There's not a heck of a lot other stuff it could be. I mean, is that really?
Yeah, I mean, it really almost in many cases becomes the opposite of rocket science. I mean, people come in and they're weak, their potassium's sitting down at 3. When they get supplemented with potassium, they're up at 4.3, they're feeling better, they get to 4.8, and they're great. And if you can get them past 4.8, I would be surprised.
So how many hypers are in the audience? Hyper. So a few. I'm like a hypo. No,
yeah, you're different.
I'm a hyperactive. Yeah. What's your feeling about potassium binding salts? So like patiromer, because there's a couple of new ones that for renal hyperkalemia and in renal chronic kidney disease, and I know that the K-axylate was, you know, Dr. Griggs mentioned that there's not much of a role for that in hyperkalemic periodic paralysis. Any comment on the new ones?
No.
Okay.
No experience with them. I haven't, you know, again, with the percentage, if you just play the percentage game, there's so many fewer. Most of the ones that I have respond really quickly and easily just to a little hydrochlorothiazide and Coke once in a while.
And role of propranolol in hypokalemic periodic paralysis?
2 purposes. There's many people will get a sort of a reactive tachycardia, supraventricular tach, particularly when they're starting to feel weak, and so the propranolol will ease that. It's also, in particularly low doses, is helpful and you know, performance anxiety. Again, it's sort of blocking that adrenaline business.
Do you think there's a role for low dose? I mean, has anyone here used low dose propranolol as a thing? Does that help you?
I was gonna ask that question because it really helps me and it makes a lot of sense. And the doctor that prescribed it just explained that it blocks potassium from going into the cell in the same way that a lot of the other medications, or different but the same, blocks adrenaline, so helps potassium. And I don't understand why other people don't use it, because if I didn't have it, I wouldn't be nearly as functional as I am. Yeah.
I don't know. I can't say that there's even a a measurable number of people in my population who I give beta blockers to, but there's certainly some. I don't necessarily differentiate. Atenolol, which is a water-soluble beta blocker, I get maybe a little bit more use out of. I've had a couple of people come in with the migraine diagnosis as part of their, because again, it's been mentioned several times, migraine's really common comorbid condition, and so family doctors, internists have known that beta blockers are great at, or can be great at blocking that phenomenon. And you know, there's so many of the periodic paralysis folks who have migraines. Incidentally, I was talking to Dr. Bell yesterday, I guess, and I've put a couple of people on these new CGRP antibodies that have been out for about a year now for prevention of migraines, and they've not had any effect on their periodic paralysis attacks at all. They call back and say, my gosh, my migraine part is gone, but I still have attacks. So there's more to it. They're not that connected.
Hi, Dr. Lewis. Thank you for your information. Could you talk a little bit about statins with someone that has hypokalemic periodic paralysis or paramyotonia congenita?
So I caught the last part of that.
Could you talk a little bit about statins with being a hypokalemic and paramyotonia congenita? For instance, I can't take them due to the muscle-soluble issue and causing the cramps and worse episodes of paralysis.
You said the statins?
Yes.
Yes,
Oh, okay.
sir.
Yeah. I hate the statins. Excuse me. You know, my answer is, if I have people who have muscle pain and cramps, unless their cholesterols are running up around 300, I take them off of any statin that they're on. I don't. There's got to be a better reason to take a statin than they just have.
Yeah, I can speak to that a little bit. I mean, I think that, you know, some people with hypokalemic or hyperkalemic periodic paralysis can take a statin and get away with it. But, you know, statins cause this breakdown of muscle as a rare side effect. And if that happens and you have periodic paralysis, there are some folks that have been thrown into kind of permanent muscle weakness from that bad reaction. And the honest truth, and a lot of, it's not just statins, but a lot of the medicines that lower cholesterol can do that. However, there are some new antibodies, PCSK9 inhibitors. They're very expensive. They're PCSK9 inhibitors. I'm sorry? I hear prices are coming down. But anyway, regardless of price, I mean, you're already on Kavea, sorry. That probably would be a very safe alternative, and it knocks the cholesterol right down. So if you have high cholesterol, there's definitely technology out there now to help that. Hold on.
Hi. It was difficult for them to differentiate between Gittleman's and periodic paralysis for me, because I was taking 240 a day of potassium. And then
I'm sorry, I think I'm going to have to come out there.
Okay.
I'm breaking myself. No, I'm deaf and I don't hear very well. So
We'll still speak in the mic.
yeah.
Okay. It was hard to differentiate between Gittleman's and periodic paralysis because I was on 240 a day of potassium, spilling it into my urine.
Mm-hmm.
So do you see that issue, or?
I would have a nephrologist talk to me,
Yeah.
first of all, and you know, kind of which came first. You know, was why the high doses of potassium?
Well, they tried having me off of it for a day, and I dropped critical, so I couldn't be off of it.
They tried having her off of it for a day, and she dropped. Her potassium dropped. So.
Yeah, if it's that easy, I mean, to me, that's your kidneys. Yeah, that's the Gittleman business.
Yeah.
Yeah.
Some questions from a web viewer.
Any special monitoring intraoperatively? Yeah, it kind of depends on how long the operation is. It's nice to get a potassium measured pre-op, intra-op if you're more than an hour, and immediately post-op. Kind of depends on whether you're general anesthesia or whether you're just conscious sedation, least harmful anesthetic. Any comments? For what? For dental work?
Well, I mean, I get, yeah, that's, see, this is tricky because anesthesia is a complicated, area that I don't deal with very much. But like, it'll come to me. It starts with a propofol. They talk, Dr. Weber mentioned a couple of conferences ago, propofol, giving maybe a prophylactic beta blocker, keeping the room warm, avoiding normal saline, maybe uses lactated ringers, and making sure that if it's for hypokalemic periodic paralysis anyway, making sure the potassium is at 4. And avoiding D5W as much as possible. Obviously, your NPO, you're not eating for 12 hours before surgery. You need some glucose. It's just, so that's a tricky.
Right, and I hear a lot of people doing better with Ringer's lactate, as an IV fluid. So when I get, surgeons rarely ever call me and ask me that, but that's usually the answer there. And I think that's part of, the last part of Stuart's question, I think he's saying propofol. He says propanol.
Well, succinylcholine, I think, has been a bad thing for folks.
Yes.
So avoiding succinylcholine.
Right, yeah, absolutely.
My question was almost exactly the same, except that I just had a surgery and it was supposed to be just a local sedation, and I went right into an attack. And I had, prior to, sort of done what I thought was due diligence as far as letting the hospital know, letting the doctor know, letting the admitting nurse, and they were all kind of brushing it off, and I gave my information, which they used once I was in the attack because they had never seen it before. So I guess my question is, and I'm thinking other people might the same, how do you advocate for that? Because we don't know the medical pieces that are at play.
Yeah, the usual really difficult questions. How do you get your point across to somebody without slapping them in the face and saying, hey, read this information or believe what I have to tell you?
It may be helpful to have a letter, if you have an established doctor who is on board with your diagnosis, get them to write a letter so that it's not you telling the anesthesiologist, it's not you telling the surgeon, it's your, at least by a letter saying, my patient has this, please call me if you have a question. It makes it a little more official.
Yeah. I mean, I have gotten requests from doctors from afar, surgeons from afar saying, I'm going to do X procedure on your patient. Is there any precaution that I need to take? And, that's usually, 3 or 4 sentences. And
I have just one comment. I've been waking up feeling very unrefreshed often. Is that like a thing for people? So, but in the morning when I feel unrefreshed and kind of tired, but I'm not paralyzed, but I'm just I'm like, man, if I just had 10 more minutes, so I do 10 more minutes. Like, man, I was like, and then you just have to get up and go to work. It's like, I just don't feel great. So I take potassium, I take 40 or 60, and it's like, I should have done that at night and just wake up very restful. And, my sister, she recently got diagnosed. She took potassium at night, and she said she had the best sleep of her life, after having that dose. So it's just
was that in the short acting, the Efricay version, or
the potassium chloride packets in water?
I mean, I have some patients who will give the a slow release version, 20 or 40 at bedtime, and they get better sleep that way.
Yeah, I mean, I think it's trial and error. I think that it's what works for you, but you have to pay attention to these things. And that's why I want, if someone has a management thing that has worked for them, this is the time to bring it up, to let everyone else know.
So mine's about sleep, though, too. I have this, it's kind of like you were saying, where I don't get that restful sleep. But as I'm trying to fall asleep, it's almost as if my body gets jolted awake. Does anybody have that? Where it's like you're starting to doze off, but then all of a sudden, it's almost
sleep
like...
jerks sleep jerks are fairly common. Most people, you think back to your high school days, somebody in the back row of the class startles awake.
Right, but it happens like to the point where I can't fall asleep. It's almost like my muscles won't do that transition into... Do you understand what I'm saying? Okay. I
Okay, well, may I? What I do when that happens, which is most nights, is I take the fizzy potassium and my fizzy magnesium, and within 20 to 30 minutes, I can fall asleep. And when I wake up in the morning, like you were saying, I feel drained. I don't feel refreshed. But after I take my magnesium and potassium, so I have learned to pay closer attention to my body than before. And as soon as I realize it, and I learned that from going to biofeedback therapy. I don't know if anybody here has tried that.
What happened? Did it die? Here, let's trade. No, it's really off.
Yeah. So, is actually a little bit of gabapentin at bedtime, too. We use gabapentin, Neurontin, in treatment of restless leg syndrome, and sort of think of it as like a variation of that. I can't get still, I can't get comfortable, my muscles are too painful, and a little bit of gabapentin goes a long way because it's short-lived.
Can you comment on magnesium?
Everybody asks about magnesium, gives me the runs.
Aluminum stops you up, magnesium gives you the runs.
It's I get mixed reactions out of the patients. It's not something that I necessarily recommend one way or the other. Some people, swear by their magnesium, and other people, they say, why am I taking this?
But with magnesium, you can overdose with orals, yes,
yeah.
no?
It'd be pretty hard to. I mean,
okay.
You have to take a handful.
Oh,
yeah.
I'm Marion Breslauer. I do use one unusual medication that I don't hear other people really use. It's called levocarnitine. And when I was younger, I couldn't exercise for more than 5 minutes before my muscles just would stop. It wouldn't let me exercise anymore. I'd just have a paralysis attack. And then since I've been taking the levocarnitine, I can exercise for an hour or even a little more than that before I hit that wall.
Sure. I mean, carnitine is supposed to be a transporter molecule for the mitochondrial membrane, helping to get product across for mitochondrial metabolism, which gives you your energy for for your cells to work. And there's certainly, there hasn't been any real discussion around that I've heard about mitochondrial DNA, and I'm sure that there's quite a few people in here who have some mitochondrial question marks, and so if there's some deficiency in mitochondrial genetic function, then the carnitine certainly is a good idea. I use it a lot in some of the stranger pediatric, now adult epilepsy syndromes as well, and it can be quite helpful there too. So it's certainly safe, and it's easy to measure. You can get a blood test and make sure you're not getting too much.
Have questions here?
I have a question about potassium. I read somewhere the other day that there may be a particular type of potassium that would be good for us. I know there's potassium chloride, there's potassium salts, there's potassium bicarbonate, and years ago UCLA Medical Clinic had me on potassium gluconate, which was a liquid, and which worked well.
Which you can get over the counter. You can get that over the counter, the gluconate, without a prescription.
Oh, really? Yeah. They gave it to me by the gallon.
Yeah. Yeah. As I said, I have patients on just about every formulation of potassium you can think of. I've had some mix and stir pharmacies will combine potassium salts of different types to put together. Some people will find if they take the chlorides for a period of time, their stomach starts getting eaten alive because of some dysmotility issues as well. And so switching to a different brand, a different flavor, if you will, of the potassium will help that as well.
Hi. I was wondering, when medications like Keveyis, Diamox, some of the other ones are prescribed, are they usually prescribed with potassium product also? That's my first question.
I don't know about usually, often, frequently. I mean, certainly not in the hyperkalemic folks.
Right. Especially if a person is hyper. Or, I mean, hypo, I'm sorry.
Right,
excuse me, I'm sorry.
Yeah, so it's a sort of a common combination. As I said, I feel like the carbonic acid anhydrase inhibitor puts a cap on the swings. Everybody's potassium swings.
Yeah.
Up and down all day long. But mine swings through a narrower level than probably Jake's does. And I don't need the Diamox to keep it that way. Diamox helps to keep it so you don't swing too high or too low, which makes it easier to recover so that you can get by with a single burst of potassium when you're feeling weak. Yeah. But I wouldn't say it's necessarily prescribed together, meaning taking it at the same time.
Yeah, like taking, somebody was prescribed Keveyis on a support group and not potassium.
Sure, I have patients.
So I was just curious about that.
So, I mean, to that effect, when you take a diuretic that is potassium wasting, by definition, you're losing potassium. So over time, be it days, be it weeks, you're going to, even a regular person who doesn't have hypo, they take it for heart failure and they take a potassium wasting diuretic, they're going to get hypokalemic and you have to have potassium supplement. And that's the main indication for why that stuff's on the market to begin with. It's not us. It's them. But so, I think it would be unwise to, for a long period of chronic time, take a potassium-wasting diuretic such as Keveyis, such as Diamox, and not have some level of potassium supplementation.
Okay, thank you. And the next question is, has any of your patients ever brought up the idea of their vision coming and going, even though they have, their doctors have told them they have good eyesight? Coming and going and possibly getting better with potassium?
Have not heard that.
I have not either.
Yeah.
It was a topic on a support group, and there were many comments of yes, the vision coming and going. Getting a little bit worse, a little bit better, and some people could correct it with just a little bit of potassium.
I would say that, lights are a trigger for a good number of people. Raise your hand if lights bug you. So I know my sister also has that. Shelley has that. And that's not like described in the literature, but it comes up every conference. So that's a thing.
I have a question about the heart. When I have a low potassium, or I have a very big shift downwards on my potassium, I get flat T waves on my echocardiogram. And I can feel it as well, that my heart starts beating irregularly. But when I'm in the hospital, they say, oh, that's a non-specific change in your heart. It doesn't mean anything. But I know that other members of my family have the same thing. And there's quite a few of us that have had a pacemaker or have had either too high pulse or too low, and I can experience both as well. So what is the flat T waves, is that kind of a precursor to the long QT syndrome, or is it like I only get it when I get it really bad if my potassium is under 3, but I can also get it if my potassium drops really, really fast?
I'm not a cardiologist. I don't quite know how to address that, but your statement about feeling your heart beating irregularly or erratically and stuff should have nothing to do with flattening of the T waves. I mean, that's an irregular pulse rate.
So this is always a tricky part of periodic paralysis, especially Anderson to Will syndrome, but also just plain periodic paralysis where you have really high potassium or really low potassium at some random points. And, there are cardiac implications to that, and there are people who have gotten into big trouble, even, die from a cardiac arrhythmia. It's not common, but it has happened. And the question is, if your potassium is just low and you have an attack and it's low, do you worry about having an external pacemaker or something? I mean, generally, I think mainly people don't do that. I think the issue is more if you see a cardiologist, you do a Holter monitor, you're having kind of funny beats, or someone catches some funny thing on EKG, even if it's incidentally, then you really should see a cardiologist. They have to make a decision, do they do a Holter monitor, and then, electrophysiologic studies, and decide if you need to be more aggressive or not. But it definitely needs to be in consult with a cardiologist. And what's missing at these conferences, honestly, even though very few people in the room may have it, but a cardiologist is someone who should be here too.
So I'm one of those people that have an unknown gene. None of the 4, I tested negative for those. And
did they do other testing? I mean, are you saying so? Is variant of uncertain significances, or just those 4?
Those 4 were completely negative, right? Okay. And I haven't had any other genetic testing other than the 4 major genes. But the question I had was, I have some long QT, and I don't have any of the physical characteristics of ATS. But I do have, and something I've read in the literature, I have a lidocaine resistance. And I don't know if, since you see so many patients, if that is something that you've seen in any of your other patients, a lidocaine resistance when they don't have ATS.
When specifically not ATS, yeah, it's fairly common in the hypokalemic folk.
The hypokalemics commonly have lidocaine resistance. Okay.
I don't know what the number is. Again, not being a bean counter, but it's fairly common that Novocaine, lidocaines don't work very well. You have to get some carbocaine or something longer acting from your dentist.
Okay. All right. Thank you.
Great. I think we'll take one more, and then we'll have a whole opportunity tomorrow as well. But I would like to give we'll take a 5-minute break after this question and maybe get ready for the doctor roundtable, then the auction, then dinner.
Thank you. When my daughter had her first paralysis attack and they were trying to figure out everything was going on, in the blood work they found that she had low cortisol level. And the local hospital thought, well, maybe that was the cause of the whole paralysis thing, and put her on 30 milligrams a day, 20 in the morning, 10 at night. Well, since then, saw a neurologist, got the diagnosis of hypo. We don't have a genetic, it's a clinical diagnosis. But we have an endocrinologist who monitors the cortisol. Then we have our neurologist who is managing everything else. But neither the two meet, and neither one of them understands the interaction. One of them suggested, is this caused by it, or is this helping periodic paralysis? Can we take her off of the cortisol? And nobody wants to talk. They don't know, and
yeah, I mean,
we
doctors
don't know.
hate talking to other doctors. We really do. It's interesting. Cortisol is one of those really tough things to measure accurately. It varies throughout the course of the day. And if it's not measured at the right time in the right conditions, you're going to get a fallacious reading. And I've seen people say that their cortisol level is low. So here it is. I think on a single reading to be treating it, I would certainly wonder whether it's really necessary and find out whether an ACTH cortisol stim test, for instance, has been done. And
what did they do?
The one.
Yes, the cortisol stim
test. They did
test.
that.
Yeah. Well, so when they give an injection of ACTH, adrenocorticotropin hormone, cortisol is what it's called, and then measure the response of your adrenal glands and how much cortisone your body makes. And there's one should stimulate the other. And if it doesn't, then the adrenal glands are not making appropriate amounts, and it needs to be supplemented. And again, when you're starting to talk about those, again, we're moving into Strongbridge's other forte.
Right, yeah, endocrinology. But I mean, the idea, and again, I sometimes, I think I even got this wrong in my presentation like 5 or 7 years ago, but so if you have cortisol, if you have a lot of cortisol around, so that looks like aldosterone. So if you have a lot of aldosterone around, you are going to take salt in your body and pee out potassium. So a lot of cortisol would make you be like hypokalemic periodic paralysis, and low cortisol would make you be like hyperkalemic periodic paralysis. And that's where you might get an endocrinology person to sort that out and just rule that out if that's a consideration. And beyond that, I don't know that I can comment.
Could they even have overshot originally? I mean, with how much cortisone was needed, and that drove you into a hypo state.
Yeah. Okay, guys, so let's take like I don't know, 10 minutes? 10-minute bio break, come back, the doctors will be on stage, and we'll wrap up the day. Thanks.
I never know what these things.
I want to make a question for you, not for me, but